We've talked about the broad categories of physical examination, which include inspection, palpation, range of motion, strength, stability, and neuro. On inspection of the human knee, you're going to want to look for signs of swelling. If you have to have the other knee unveiled or you're not going to be able to compare. You cannot examine a joint without the control of the other limb in the peripheral joints in the body. For swelling, look for an area that's concave and go ahead and look and see if it's concave on the other side or convex. Okay? Look to see if there are incisions. Many people do not realize that arthroscopy is a surgery. If you find scars, they may have told you they didn't have surgery, but then they will say, oh yes, I had an arthroscopy. Look for muscle patterns to see if you've got atrophy or not. Look for obvious signs of skin changes such as erythema. Palpation, the triangle on the knee is very important to understand where the joint line is. And the hypotenuse of the triangle is the femoral condyle. The patella and patellar tendon is inner, and the base of the triangle is the tibial condyle. The joint line will then go down 3 to 10 degrees, so you'll follow it down and posteriorly. So on palpation, you need to have a system. You start with quad, patellar tendon, patella, and tubercle. You're going to feel the joint lines all the way back. You're going to feel the collateral ligaments. You're going to go down to pes right here and feel down at the tib-fib joint. Normally we would go to range of motion, but since the exam is also seated, we're going to do 3 patellar tests. We're going to do the patellar grind, where we increase contact forces in the patellofemoral joint. Crepitus should be noted. Crepitus can be normal, but if it's asymmetrical or painful, that should get our attention. We're going to do the patellar apprehension to see if coming up into extension, this elicits apprehension in the patient of impending instability. And we're going to look for a J sign. Does the patella track up, or does the patella then jump laterally like an inverted J once it's out of the trochlear groove at less than 20 degrees of knee flexion? Okay, can I have you lie on your stomach? In looking at range of motion, scoot down the table, knees right on the edge. If you don't look at a patient prone, you will miss flexion contractures or loss of extension. 1 degree of lost extension is 1 centimeter of heel height difference. So if you had a 5-degree flexion contracture, you'd be 5 centimeters higher in the air. At 5-degree flexion contracture, you lose 30% of quad efficiency. Okay, can you up on your back? With knee flexion and flex this knee, look at the knees. If you want to use goniometer, obviously this is 90, it's 45, this is 135. So you can look from the side and see if they're equal. You can measure if you want. The hardest part of the physical examination for students is the ligament exam, and it requires some sort of bump. It doesn't have to be a plastic bump like this. It can be a rolled up towel. We use a bump for 2 reasons. One, the ACL, MCL, and LCL are most loose at 20 degrees. 2, the knee will relax. If you ask someone to hold an injured knee up in the air, they'll guard and form a muscular cage with their quadriceps and hamstrings. Okay, to examine a ligament in the joint, you need 1/2 of the joint fixed and the other is mobile. If I just do this without immobilizing the femur, I'm dissipating forces in the hip. If I fix the femur and go into valgus stress, then I will be getting the MCL on tension, and I'll be able to feel laxity. LCL as well, you need the contralateral side each time. ACL, fingers on the joint line, palm on the patella, the femur's now fixed, pull up behind, and you can feel this patient has some laxity of their ACL. Okay? The PCL is most loose at 70. Okay. So with the PCL, we would look from the side, and we would see if the tubercle is more prominent than the patella, or whether it's recessed. If one side is prominent, the other side is recessed, it is the recessed side that has the PCL because increased posterior translation of the tibia. The McMurray we do last because it may hurt the patient. You can bend the knee, hyperflexion, or you can put more valgus stress on for the lateral meniscus. As you go into deep flexion, your posterior horn, middle horn, anterior horn. In varus stress, anterior horn, middle horn, posterior horn. Okay? And that is the knee exam. Thanks.